respiratory infections, we can make these clinical trials for something like 1 year, one trial, but for TB, this process it takes much longer time. So, for example, our clinical trials, phase 1 and phase 2, is lasting for several years. However, I think that finally they will be effective. Moreover, the results we obtain right now, they, in my opinion, seems really promising. But let's return to virus. Talk a little bit about RSV. So in 2019, the World Health Organization estimated that RSV causes around 33 million serious respiratory infections per year, with more than 3 million hospitalizations and something like 60,000 deaths. As for now, no vaccines are available despite the more than 50 years of the research. The first attempts to make the vaccine against RSV were made in something like 60s or 70s, and it wasn't successful. The approach that was used is the inactivated vaccine that were inactivated by formalin. But this kind of the approach didn't give any good results. Moreover, in the experimental groups of children who were vaccinated with formalin inactivated vaccination, it didn't give any protection, but even led to the worsening of the disease and even several deaths. So such horrible results stopped this research concerning RSV for something like 30 years. And only at the beginning of our century, the different kinds of experimental works in order to develop the vaccine against RSV started. Now we know the problems that we met 50 years ago was linked with different kinds of immunopathologies such as antibody disease enhancement. Now we know this mechanism, we have the ideas how to avoid it, but at that time nobody didn't know about this problem. So by the way, the same problem concerning antibody disease enhancement is one of the problems that we can meet with the development of the COVID-19 vaccines. The results of the preclinical trials and the clinical trials that we have now showed that probably it's not a big problem, but let's keep in mind that we can make the final conclusions only after registration and post-registrational trials of the vaccines against coronavirus. So anyway, the developers have to keep in mind these immunopathologies like antibody disease enhancement or something like this. So let's return to our vaccine platform. So we decided to initiate this work in order to make the vaccine against RSV on influenza virus vector. So addressing this challenge, we created several recombinant candidate vaccine viruses on the basis of the NS124 influenza vector. All viruses carried highly conserved sequences of antigenic sites 2 and 4 of the RSV surface F protein. The viruses, candidate viruses, differed by signal. They differed by linker sequences that was inserted between NS1 open reading frame and the F antigen regions of the RSV. All constructed viruses were stable during passages in chicken embryos and expressed chimeric NS1 protein after infection of MDCK cells. Safety profile of these candidates was tested in mice. All viruses were fully attenuated when administered at the dose that is shown on the slide. At higher doses, there were slight differences between these candidate vaccine viruses in mouse weight dynamics post-immunization. However, all the candidate viruses were attenuated in comparison to wild-type strain and even in comparison to empty vector. Further screening protection study was performed in mouse model. The chosen immunization dose and the chosen challenge dose are shown in this picture. We detected the decreased lung viral load and microscopic lesions in immunized mice in comparison to non-immunized mice. The most prominent result was shown for the vaccine candidate number 3, and this group was chosen for the further histopathology study. Histopathology study in mice from this group was done in comparison with non-immunized mice and also mice that were vaccinated with formalin-inactivated RSV virus before the challenge. So this is a kind of the vaccine what was initially done 50 years ago and led to immunopathology. So the lead immunization with this formalin-inactivated RSV virus showed the typical severe inflammatory histopathological lesions. Lung tissues from our candidate virus immunized mice didn't show overinflammation, and the total damage score was decreased in comparison to non-immunized group. The study of particular immunopathology markers after RSV challenge, such as eosinophils and goblet cells, showed the complete safety of immunization with this candidate virus in opposite to formalin-inactivated RSV group, where these markers were significantly increased. Therefore, immunization with our influenza vector induced a balanced and controlled immune response critical for a safe vaccine that wouldn't cause disease upon RSV infection. So this work is now going on. Right now we do the experiments on cotton rats, and I hope that after we obtain these results, we can for sure tell whether our vaccine is promising for further clinical trials or not, but I hope that the results will be good, since all that we obtained previously really makes us feel that we can obtain a good protection using this influenza virus vector against RSV. So now let's return to COVID-19. There are really many similar things concerning the vaccine development between RSV and COVID-19 vaccine, because all these infections are respiratory infections. We can imagine that there can be some antibody disease enhancement, and we have to keep in mind when develop this vaccine. And the T cell and B cell immune response, the balance between them is very important for both these vaccinations. And so when we met this problem at the beginning of this year, we decided to use our approach in order to make the vaccine against COVID-19 based on our influenza virus vector. So now we're at the stages of the preclinical trials also, but we have already obtained some results, and I'll present it right now, these results right now. So we have made a vaccine candidates based on this, our vaccine platform of the live attenuated influenza virus. Each vaccine candidate, we obtained 2 vaccine candidates, they have several unique properties. First of them is a flu-based vaccine, and it can be combined with the seasonal flu vaccine strains. So in order, if this project will be successful, we can obtain 2 vaccines in one. We can vaccinate against influenza virus, changing the hemagglutinin and neuraminidase composition. And also we can make a vaccination against SARS coronavirus, because we suppose, and I think that most of the virologists suppose, that sooner or later this SARS coronavirus 2 will become the seasonal virus, and we'll have to vaccinate against this virus maybe each year, or maybe several times, one time at several years. But anyway, it has a very good chance to become a seasonal virus. Also, this influenza vector carrying COVID-19, sorry, not COVID-19, but coronavirus antigens, is attenuated with the deletion of the key virulent element and immune antagonist in S1. It is potentially be more immunogenic than wild-type influenza virus. And important things concerning the manufacturing facilities, that can be produced in chicken embryon eggs or MDCK cells, which is a proven production system for influenza vaccines, and it means that the existing manufacturing facilities can be easily adapted to the production of new types of vaccines against COVID-19. Also, it uses flu vector to express a specific antigen to induce immunity targeting the critical elements of the receptor binding domain and the nuclear capsid of SARS coronavirus. So we have chosen these 2 coronavirus proteins. So we choose the receptor binding domain of the spike protein. So here it is in the picture. And also we use the nuclear capsid molecule of coronavirus in order to produce not only B cell, but in order to produce mostly T cell response on this nuclear capsid protein. So such strategy may avoid potential antibody disease enhancement as observed in some experimental vaccines for the SARS-CoV-1 viruses. And also another important advantage I have already told about is that it can be used as a nasal spray. So finally, we obtained the bivalent vaccine composition that is, we hope, that is capable for the formation of a long-term cross-protective respiratory immunity resistant to the evolution of the SARS coronavirus 2 virus. So what else? The next things that we made, we've studied some immunological characteristics of these candidate viruses in mice. So the vaccination induced strong CD8 plus memory T cells response against both recombinant proteins of SARS-CoV-1 that are used in our vaccine composition. This is RBD domain of spike protein and then protein of the virus. And also here on this picture on the left, you can see our results concerning DNP. This is the protein, nuclear protein of influenza virus. So the results they obtained, they are, in my opinion, they are rather good. And now we hope that during the next month we start some challenge experiments concerning the virus challenge on some animal models. And I think that till the next year we'll obtain these results and can finally understand whether our idea was good for coronavirus or not. But also I'll repeat once again that in my opinion, using of influenza virus vector is a really promising platform for respiratory infections, including coronavirus. But whether it's right or not, the time will show us. So at this final slide, I would like to thank all our colleagues who made this work. So here on the picture, you can see the Laboratory of Vector Vaccines of Influenza Institute, and that is working in collaboration with Polytechnic University. So this Marina Stukova, she is the head of this laboratory and the principal investigator of this project. Also, the TB vaccine was developed by a big collaboration. It included Influenza Institute, the Institute of Biological Safety of Republic of Kazakhstan, the Institute of T-Zero Pulmonology, it is also located in St. Petersburg. Then RSV vaccine project is now funded by the Center of Strategic Planning of the Federal Medical Biological Agency, and the COVID-19 vaccine research is partially supported by the Ministry of Science and Higher Education of Russian Federation as a part of a world-class research center program Advanced Digital Technologies. So that is all. Thank you for your attention.
Thank you very much, Dr. Andre, for this presentation. Now we would like to open questions. While we receive questions, I want to touch one important point that you touched, Dimitri touched, and I think everyone is interested, including clinicians, journalists, and members of the public, and when a vaccine will be available. So, and as you mentioned, it will be when one of those candidates demonstrate to be safe, effective, and available. But would you like to elaborate more on these questions that I think that is of everyone's interest?
Well, I can give a short comment. So when we talk about the availability of the vaccine, we are talking about two things. First of all, we have to develop the vaccine and show its safety and immunogenicity, so that the vaccines that are now on stage 3 of clinical trials, they are close to the same. Probably these adenovirus-based vaccines or some RNA vaccines, they probably can be rather effective at this stage. But the most important thing, in my opinion, is the manufacturing capability, because the technologies, they are comparatively new. They are not widely used. anyway, because most of the vaccines that are widely used worldwide, they're based on some kind of older technologies, that's inactivated vaccines, some recombinant vaccines that are comparatively rare or something like this. And the vaccines based on viral vectors, they are not well established, there are no well-established manufacturing capabilities. And I think this is the key component. Whether we could scale up this production, how many doses will we do? And I think that nowadays nobody can answer this question. Sure, we hope that we'll obtain these vaccines at the end of this year, at the beginning of 2020, but I don't know where it will be so, because we have made the vaccines that will able for everyone, not for some people in US, for example, in Russia, partly in Colombia, but for the whole world. And it's a really great challenge and a great task. So I'm not really very optimistic concerning that we obtain this vaccination for all in the nearest month, for example. But let's see.
Thank you. I have a question for Dimitri regarding the alpha virus vectors in general. How safe are they to be used as a vector for vaccine production?
It's 100% safe. Actually, do you know, in general, we are not using alpha virus. As you know, we are just using non-structural genes for self-replicating RNA. And I understand your concern about Latin America, because you have Venezuelan, you have Eastern, and you have Western equine encephalitis. But do you know, it's 200% safe. The main issue just delivery. We have to decide what we are going to use. Lipid nanoparticles or golden beads. And what the method which we can use. Definitely it has to be intradermal. But how you can deliver by a kinetic method or just micro needle or tuberculin syringe, this is kind of you have to decide. But it's 100% safe, 200% safe.
Well, based on some platforms that are out there right now, there are also a concern of using RNA vaccines. Is there any safety concerns that you know about?
Actually, right now we don't have any. And keep in mind, ID, intradermal. I don't know, it has to be replicated inside dermis. Maximum what you can have, it's just local skin reactions. But this is unlikely, because it's just a teeny tiny amount, 2.5 microgram, nothing big. And even more, you don't have to worry about reducing immunity. And you can shoot as many as you can, because Edna viruses can, do you know, each person in the world being contacted with Edna, and we have cannot predict. But with RNA, you know, we have tons of RNAs inside our cells, inside the body. This is safe, and this is in the beginning. My concern is this can cost not $1, but when you have, I mean, the good facility for doing this, it will be even cheaper than a live attenuated vaccines.
Yeah, it was one of the questions too for Dr. Basin. What is the cost of these vaccines?
The cost of influenza vaccine, it should be comparative to the cost of the influenza attenuated virus vaccine, since it's probably just the same vector, the same kind of the vaccine. So I can't tell you the exact price because the cost per dose in different countries differs. So for example, in Russia and the US, the cost for these attenuated live vaccines, this different numbers, but it is comparable to the common influenza vaccination.
Thank you. I have one comment from Maria and some questions. She said, you have shown great approaches to vaccination. The flu vector seems much more limited in terms of size of foreign antigens that can be expressed. Is this a serious limitation? And what is the size limit?
Yes, Maria is absolutely right, because one of the disadvantages, I have told many things about the advantages, but for sure there is no ideal vector, it has disadvantages, is the limitation in length, because this NS gene is the smallest gene segment of influenza virus, and so the maximum size of the proteins is just several hundred amino acids. So for some epitopes or something like this, it's enough, but for the full-size proteins, for sure, it's not enough. So this is a really big limitation. That's why they used this vector, first of all, in order to provide a T-cell immune response, and we put some T-cell epitopes or some regions like receptor binding domain of, for example, surface proteins. So there is a real limitation. This is one of the disadvantages of this virus vector.
What is the size limit?
The size limit is something like maybe 400 amino acids or 500 amino acids maximum.
Thank you. So for the saRNA vaccines, it is known if material vaccination protects the offspring. Also, has this been tested for flu vaccines?
Actually, I don't know whether it was shown. Maybe Dmitry can tell something.
Would you mind to repeat the question?
Oh, so sorry. For the saRNA vaccine, is it known if maternal vaccination protects the offspring?
Maternal, what do you mean?
If you vaccinate a mother that is pregnant, so will the
actually, you know, it has to be tested. I mean, for I do not believe that it will be kind of an issue for vaccination of the in pregnancy, and of course for newborns. You are talking about, can we use, let me rephrase it. Can we use self-replicating RNAs as a vaccine for all ages? Yes, we do. And also, even for immunodeficient people. You know, we are just mimicking this process, I mean, immune response. And for adults, definitely we can increase, I mean, the dose, because immune responses in elderly people are lower, even for flu, because right now it's a big talk about, right now what we have inside flu vaccine. 15 micrograms and for each strain, for influenza A, 2 strains, and for influenza B, 2, for or quadrivalent vaccine. And right now it's underway, the clinical trials. You have to increase the dose for elderly, and for kids definitely you have to get less because they are waiting less, and it's described well in product and source for freelance and how much you have. And definitely it has to be branded for kids, for adults, and for elderly. Right now, I got your point. And for in pregnancy, definitely it has to be the separate clinical trials as a normal. And it's well I described at FDA rules and of course at local regulators in Europe and at PAHO, Pan American Health Organization, and then even in Japan, it's exactly the same, the procedure for. But you have to do clinical trials. And this is just you have to wait what we can gain to if you rephrase it to or replace it to COVID. The people are dying and you have to do something. And even more, you can just use the other type of the in terminal stages when they're on a ventilating machines, they're using kind of plasmas to stop it. And in 80% it's working, but they're losing it. But without that, we can lose some 100%. People will pass away. If you are doing, plasma or globulins, it's exact. You can save 80%, but you can. It's complicated. Thank you for asking that. But, well, we are moving from just medicine for mass to the personal medicine. And I don't know if ideal case has to be chosen by exact stage of the patient, age, and but it's a medicine. But it costs money.
So, and do you know if this has been tested in flu vaccines to see if the vaccination in pregnant women will protect also the newborn?
Fetus, yes. And but not for a while. It will actually, maternal antibodies can protect, but not more than 1/2 of the year. Did I answer any question?
Yes. Thank you, Dimitri. So I have a question for Dr. Andrew. What kind of antigen are you using for coronavirus vaccine, the chimeric flu coronavirus vaccine?
Yes, we use two antigens. The first one is the receptor binding domain of spike protein, and another is the several regions of the N protein of coronavirus.
And since you are using the receptor, the ligand to the receptor, do you expect that those vectors can enter other cells, or what is the safety profiling that you are expecting for this?
Well, the route of administration is the intranasal route, so the epithelial cells is the main place of destination of this virus. And since we've obtained a good safety profile in other vaccine candidates, such as RSV, TB, and also some other things that I didn't mention, so we hope that the safety profile will be good, but for sure we didn't make the safety experiments on the preclinical trials, so we'll update it also later. Now we're just in the middle of the preclinical trials, and we now have plans to make the virus challenge first of all, and then we'll make this safety profiling, but it will be done later.
And what is the percentage of protection or efficacy of the flu vector?
In COVID, you mean? In COVID-19?
Yes.
Yes, but we didn't make this challenge right now with only the obtained results of immunogenicity in mice, not infected, but the experiments with the infection will do it in the next month. So we didn't do it yet.
And for the vector per se, is it 100% against flu, or how does it work?
Against flu, yes, it is close to 100%. I don't keep in mind these results. I don't remember them, but they're because initially this vector was used as a kind of attenuated influenza vaccines, including H5N1 viruses, or something like this. So the results was good. The protection was 100%.
It's me. Actually, usual life attenuated vaccine can protect at least for 5 years or for a whole life. But with influenza, you have to keep in mind, and they have antigenic shift and delay. And I think for a whole life, if you've been once vaccinated by life attenuated, but flu is a different story. They have many variants, and you can be protected for a whole life. An example for Spanish flu, but you've been at least naive for a Hong Kong flu, and because there are just diverse strains. But with COVID, actually, if the virus will not change, definitely you will be protected even more than 5 years. And what we are usual, you have to keep in mind, coronavirus infections, they are common, and we don't have any, because common flu, what is that? Real flu or rotavirus or rhinovirus? So the question has to be returned to our advisors, World Health Organization. If the strain for a flu will not change, definitely will be protected for a way better versus split or subunit flu vaccines. That this is what I want to answer.
Thank you. So we have a question from Andres Villa. Do you think that the use of an adjuvant will help to improve this vaccine?
Which one?
Well, I guess the saRNA vaccine.
Well, we don't have to have an adjuvant. In general, if you memorize, and definitely you are, we are using adjuvants only for killed vaccines, not live attenuated. It's not going to work. And usually, I mean, in the normal vaccination, what you are using, just, 10 to 3 platform unit. This is for rubella, mumps, measles, even more for all type of vaccine. You cannot go more than 10 to 3 PFUs. And in the kill vaccines, what we can do, you have, it's less immunogenic, and you have to use adjuvant to increase the, and this is not kind of, and usually they can give you protection, an example, flu vaccine for 1 year, but this is because strains been changed annually. For a plaque, you can be vaccinated from 1 up to DTPs. Yeah, you have to use it. Even, I mean, this is why we are using adjuvants, and we don't know the long term for that. Is it good or bad? This is the big question. Because you know, you can decrease the amount of antigen, but you are adding adjuvant inside a vaccine formulation, and we cannot tell what is gonna be. And the same thing for preservatives. Some people are talking about mercury labs is good, or the other ones. No, it's a good question. But adjuvants definitely can decrease internal costs. But WHO, what they want, no adjuvants, no preservatives, and I don't know, the price for that is gonna rocket high. And an example in Africa, who's gonna pay for that? Charity, definitely, yes. But they, even for life attenuated manufacturers, what we can do, we can go not less than $15 per dose. Plus, and this is WHO recommendation. And hard question.
Thank you. Dr. Andrew, are you worried about enhancing antibodies on your chimeric vaccine for coronavirus?
I can't tell that I'm really worried about this thing. Maybe in spring there were many talks concerning antibody disease enhancement in this virological society. But now, as we have the results of the preclinical and clinical trials of different vaccine candidates, as I know, there were no reports concerning this antibody disease enhancement effect. So probably I think that we shouldn't meet such a problem using that technologies that are used nowadays for vaccination. So I hope that we won't meet this problem.
Thank you. There is another question here from Andres. What kind of assays are you doing to follow the secondary effects or possible secondary effects of these vaccines?
What do you mean secondary effects? I can't understand this question.
I don't know. So the question is talking about secondary effects. Maybe he's trying to ask if you are expecting any side effects.
Well, the side effects probably will meet them at the clinical trial stage or something like this. Because, for example, toxicity or something like this, for sure, we can find out using the animal models, studying toxicology in the case of preclinical trials. But all the side effects, they are studied using the common techniques during the clinical trials. I think that we don't have something new that nobody used. Just we use the techniques that are used everywhere.
And another question from Andres for both of you. Could those vaccine platforms protect us from other coronaviruses?
Well, if talking about it, it will depend on the design of the vaccination, because if we'll use this receptor binding domain of spike protein, probably it won't give cross protection, because this region is specific only for SARS coronavirus 2. But if we'll speak about the epitopes of N protein, here we can really obtain some cross protection, because it is more conservative between the different coronaviruses, and moreover, there is data in literature that there is a cross protection, especially when we talk about the T-cellular response among the coronaviruses. So in this case, we can imagine that we can have a cross protection for these epitopes of the N protein. But sure, we'll tell whether it's so or not only after the experimental improvement of this. But we can imagine that some cross protection on using these T-cell epitopes is possible. It depends. It is for the influenza virus, for siRNA, or for other vector platforms, because the general thing, it doesn't depend on the vaccine platform. But basically depends on the design of these antigens.
Andre is exactly right. Let me rephrase it. For SARS, MERS, definitely, as much as you insert, it can work in theory. But Andre is always right that we have to try. And how come we can try? We have to gain clinical data. But for other coronaviruses, I am not sure, because do you know, some cross protection can be, because usually, you know, we are all get catched in the use or in the whole life coronaviruses. So it's called like a common flu. And we have to think about mortality rate. If it's exactly with influenza. Why we are vaccinating population? To reduce mortality rate. Since the vaccination being introduced and 60% of the population being vaccinated, mortality rate in Russia decreased in 22 times. And the same thing with hospitalization. It costs money. As less people can get inside the hospital, this is a benefit for this. And cross protection for SARS, MERS, they are very, very similar. Definitely, in theory, yes. But for other corona, I'm not sure. Because we have immunity. And clinical trials has to be with, if we will introduce it to newborns and do exact, only that can answer on the question. I mean, that's the kind of data. Because we have even Konstantin Chumakov told that IPV, not IPV, normal polio, live attenuated, can give you cross protection. It's tricky, but do you know people which been vaccinated by live polio vaccine, which been developed by Elder Sabin, can protect? I want to argue or just say pro or contra, but sometimes it's working in a mysterious way.
I'll mention.
Go ahead, please.
Polio, or for example, BCG, it can give a cross protection, but it's not a specific cross protection. If we talk about the seasonal coronaviruses, in this case, we call it about the specific cross protection. So it's a very important thing.
So there is one question about regarding the production of these vaccines. Will be enough amount to distribute to all people, and how easy is to produce them?
Well, if we're talking for the vaccine on influenza virus, it is rather easy to produce because millions and tens and hundreds of millions influenza vaccines are made annually, and so we can use these manufacturing facilities used for attenuated live influenza vaccines, or after some modifications, the facilities that are used for the inactivated influenza virus vaccines. So I think it's one of the easiest way to produce the millions and millions of those vaccinations. If we'll talk about the siRNA, here in theory, it can be also easily produced because there are no need to use cell substrates, chicken eggs, or something like this. But it's a new technology. We don't have it right now. And so let's see. I think that in the future we'll find out whether it is so easily as they imagine, or are there any some complications.
Yes, Andrei is right, and you have to keep in mind, even for a live attenuated vaccine, how many manufacturers in the world? I mean, we have 5, 7, and of course, I mean, MedImmune, it's kind of 3 miles away from you, can reproduce easily our Andrei's technology. But by the way, in reality, tech transfer from one manufacturer to the other one takes years as a normal situation. An example, I've been involved in tech transfer HPV vaccine from States to Russia, and of course we still working on that, but mostly it's just not technical. It's a big issue when the lawyers are playing games, and this is one of the issue, because copyrights, it's not exact Albert Sabin. He gave polio for a mankind and just declined any copyrights. But right now what we are having a battle in the big pharma, who is going to be first, and this is just an issue. But in theory, I mean, to make a tech transfer from one manufacturer to the other one, they are using exactly the same machine in the whole world. And doesn't matter, it's Sanofi, Novartis, Pfizer, the process is exactly the same.
I am glad you touched that point, because there is a question related to that, and it is what kind of obstacles these vaccines have
Sorry?
on the political point of view and the health care system, and also how this vaccine relates with other vaccines like the ones from Pfizer, Moderna, Johnson and Johnson.
You know, in the past they've been kind of, I mean, when they eradicate the smallpox, you know, United Nations been regulator, and when they been at the final stage of smallpox eradication, they just use the one strain. All manufacturers been standardized, and they gave to the mankind exactly the same vaccine. It was a dry form, and even more, they supply by devices, because for vaccination you have to standardize all. But right now, what we have many vaccine candidates. No one can tell which one can be chosen, or two. But at least they have to be equal.
This question is from Monica. If 80% of the population is asymptomatic and the virus is already spread and have induced some kind of immunity, what is the benefit of have a vaccine now?
I don't know. And it's a really hard question, and this is why I show it up, we have to just follow Hippocratic oath and just do as best as we can. And of course, we have to collaborate with each other, and we can do just, I mean, as best as we can. What can I say? It's hard, but we can. And of course, we have to think about not only vaccine. They are just thinking, let's do vaccine. But what about, I mean, drugs? Vaccine cannot, only rabies can prevent when you've been bitten by a dog. Of course, you can, but we have to think about other type of medicine. And it's complicated, but you know, possible WHO or United Nations can provide us, I mean, the guidance, how we can move forward. It's hard, but we can, and we should.
Well, I'll make one remark also. So in my opinion, that this SARS-2 virus can become the seasonal infection, as for example, other seasonal coronaviruses, influenza, RSV, and something like this. However, as we see right now, there are many complications about which we don't know. This can be not only pulmonary, but for example, neurological complications or something like this. And even in this case, if it will become the seasonal virus, it will adapt to human population. The vaccination can be necessary as it is necessary for influenza in order to make this complication less and in order to increase the number of deaths from the coronavirus pneumonia or something like this. So I think that vaccinations really doesn't depend on that situation, because we should think about the future, and if it will be seasonal infection, it is better when we have vaccine than vice versa.
Okay, thank you. There is one more question here, and is related with your effort, and if there is any collaborative work with other big companies that are trying to develop a coronavirus vaccine.
We are thinking about that, and of course, I mean, with local manufacturers, we have NDAs and we have LOIs. It means cooperation agreements, and I don't know. We are scientists, and of course, we can do R&D, but definitely we are having an agreement with industrial partners. And of course, industrial partners can do just tech transfer for all the countries, and we are open for all kind of collaboration. And you know, we completely forget about, we have to do exchange grad, undergrad students between universities and polytechnic university, and of course all universities we can. And meanwhile, we are just a part of global viral network, and of course we can share our knowledge and of course our expertise, and anyone very welcome. Big companies is big companies, but sometimes it's hard to collaborate, but right now possible. It's the right time to start and share knowledge, because people are dying. And we have to do something.
So I have a question also for Dr. Andre. This flu vector will be the one isolated every year, or is just a standard vector that you are using? Thinking that in the future, if there is a strain of flu virus circulating and a coronavirus, different coronavirus circulated, you just isolate them and create a new vector, a new vaccine, chimeric vaccine?
Well, it's a very good and hard question to answer, because now the vaccine candidate that we develop right now is a vaccine candidate for this pandemic situation. But actually, we keep in mind that if it will become the seasonal virus, we'll make a kind of the 2-in-1 vaccine against influenza, when we'll change this hemagglutinin molecules each year, as we do now for seasonal influenza vaccines. And also probably we'll have the opportunity to change the epitopes for coronavirus, but it will depend on its variability, because we now understand the rate of mutations of the coronavirus, but we don't actually know what will be in future. Right now we see that this rate is not very high, but we'll see. So I can't tell you sure what will be the final composition of this vaccine and what will be the final niche for this vaccine. Also, one important thing that we can mention is that if they make this vaccine against coronavirus, for example, and then after administration, we'll obtain the immune response to the hemagglutinin molecules of the influenza of this vector. So it means that if we'll use the same vector for other infections, for example, we obtain the pre-existing immunity, and the efficiency of such vaccination will be lower. But here we have the opportunity for different infections to change these hemagglutinin molecules, to change the senescent vector in order to avoid this situation. But actually, since right now we don't have registered vaccines based on influenza vector, so we keep it in mind, but sure, we think about it, but still we have to pass all the clinical trials and make registration, and then we will think about all these things later.
There is another question here, and it says, is there any rejection for this kind of technology in the anti-vaccine movement or something like that? I guess that, I hope that's the correct translation.
Well, I think that anti-vaccine movement doesn't depend on the technology. They are against each vaccination. It doesn't depend where it is. A vaccine against poliovirus, whether it's influenza vector, or something like this. So I think they're against vaccination at all, and the technology doesn't matter for them what technology is used or not. One of the advantages of influenza vector that it's a kind of the well-established technology. It's not something new, since the live attenuated vaccines are applied for many, many years. And we don't see that there are some complications. So maybe it can be kind of the advantages in order to, when we're talking about this anti-vaccination movement. But once again, I'll tell it doesn't depend on the vaccine platform.
Another question talking about reinfections and if it is associated with antibodies that doesn't protect, and how it can affect the vaccine development.
In general, if you are vaccinated well, I definitely, even the virus can get inside the body. Virus can replicate, but you don't have any signs of disease. And usual revaccination are required only for killed vaccines or inoculated. An example, in the past, it was just one shot for mumps, rubella, measles. Right now, they are recommended to revaccinate after. The same thing with yellow fever. But if you've been once vaccinated against yellow fever, I do not believe even you will catch the virus, you will be exactly dead. You will have kind of mild of disease. The same thing with smallpox. If you've been once vaccinated by vaccine, even you got a tons of smallpox contacts, and you've been lucky to catch the virus, you will not have that, deadliest form of the pox. By bacterial, definitely, it has to be reactivated. But COVID is a new one, but it depends if you are gonna do just kill vaccine plus adjuvant. 100% you have to be vaccinated each year. But with live attenuated virus, which can very hard to get, I do not believe you can get reinfection. Even if you can get reinfection, you will even do not know that you catch it. And you will definitely not spread it because you have antibodies. It can just, restimulate your immunity. Did I answer any question?
I think that the question is trying to address if there is it could be a possibility for antibodies not protect that are not protecting, that could be favoring new outbreaks.
In theory, if you are immune, you cannot get outbreak. And in a theory, if you have 60%, you don't have any chance. We'll see, but I do not believe that it's super duper virus which can do something different.
Well, I think now we are almost reaching the final of this interesting forum. We would like to ask the speakers if they have any conclusion remarks, any message they can send to all of our followers, and yeah, just to close our event.
Okay, so
thank you very much, Juan.
So I would like also to thank organizers, and I would like to thank all people who are connected to our session. And so I think that the problem of vaccinations against coronavirus is one of the biggest challenges that we met during maybe last 10 to 20 years or something like this. And as we see, in spite of all the developments in technologies, especially of the last 10 years, making vaccines against COVID is a very, very hard task. And actually, I think nobody knows when we obtain these good results. And so the one thing is we understand that only international communications, only collaboration between the laboratories will help us to achieve of these results. And so I hope that such kind of seminars is a very good thing when we can exchange our opinions between the virologists, scientists of different countries. And also I would like to thank once again Juan and all your colleagues for the opportunity to participate in this event.
Dimitri, any conclusions?
United we stand.
Well, thank you. I think that it is very exciting to see other platforms that have been developed for this pandemic. I think that we are living a moment of high excitement seeing a lot of people working, most of the science working in coronavirus and putting new ideas out there and testing new ways to produce vaccines and other therapeutics against coronaviruses. I hope these kind of events will allow us to interact each other and to enhance all those efforts that we are making to fight coronavirus. So with this, I would like to invite you next week for our next forum. I don't know if Andres has the invitation for the next one. We would like to see our speakers. Andres or Alonso?
Thank you, Juan. Accepted. Definitely, we can. Can you hear me?
Yes. I'm waiting for the advertisement. We may have some technical problems, but let me see if they will help us with this.
Thank you.
Please don't hang up. We are still waiting. Andres or Alonso?
Are we ready?
So our next forum, we will talk about ethics and the divulgation or diffusion of science during these pandemic times. We have two speakers, Francisco Chavez Espinosa and Daniel Silva Sepúlveda from Chile. And our moderator will be Dr. Jorge Osa. So everyone is welcome next week. So thank you very much. And with this, we want to say goodbye and please stay safe. Thank you.